The broadcast is now starting. All attendees are in listen-only mode.
Good morning and welcome to this new webinar organized by the Maternal Health Supplies Caucus of the Reproductive Health Supplies Coalition in partnership with Smiles for Mothers from Nigeria and Merck for Mothers. This is our first webinar of the year. So happy new year to all of you. I'm sure this is going to be a much better year than the last we had. My name is Milka Dinev. I'm the technical lead for the Maternal Health Supplies Caucus, which is chaired by Emma Clark from U.S.A. You are all muted right now in order to prevent background noises. This webinar is being recorded and a link to the audio and video will be sent to all members of the caucus and all participants in a couple days. We will not open the microphone, but you are most welcome to write your questions in the questions box at the right-hand side window of your GoToWebinar platform. We have a wonderful group of presenters today, so it's my big pleasure and honor to introduce Dr. Uchenna Igbokwe. He's a principal at the Solino Center and the director of Smiles for Mothers in Nigeria. When we invited you to this webinar, we shared the bios of all our presenters, so you can see that he has vast experience. They will be sharing today an overview of the work that has been done in Nigeria by following a human-centered design to develop innovations to reduce postpartum hemorrhage. So without further ado, Uche, the microphone and the camera is yours.
Thank you so much, Milka, for that introduction. And good morning, good afternoon, and evening, colleagues joining from all over the world. It's really an honor to be speaking to you on the Maternal Health Supplies Caucus of the Reproductive Health Supplies Coalition today. I'll be joined by some of my colleagues as well, and they introduce themselves as they speak. As we said today, we're speaking about the Smiles for Mothers project, which is a postpartum hemorrhage reduction initiative in Nigeria using human-centered design. And we're going to be speaking to our experience designing an innovation in 3 states in Nigeria and walking you through some of those. We also hope and anticipate that in the future, as we implement some of these interventions, we might also have the opportunity to speak to the caucus again, as this is very important maternal health intervention that has applications to what we do all over the world. Next slide. So as you all know, Nigeria has one of the highest burdens of maternal mortality in the world. And 1 in 5 of the maternal deaths in Nigeria are attributable to postpartum hemorrhage. So this intervention is quite important, as is a priority of the Nigerian government to also tackle maternal mortality head-on. And this was a mandate also launched by the Federal Ministry of Health in 2019. Amidst the plethora of systemic issues we have in Nigeria that results in maternal deaths, a big one is really around the availability of good quality uterotonics to prevent postpartum hemorrhage. And this is a big issue because we found, and studies have documented, as high as 74% of oxytocin injections having quality issues when assayed, as well as high as 34% of the misoprostol having issues. This is due to issues around temperature as well as humidity and stability, which occurs right all the way from procurement but through storage and use. So the revision of the 2018 WHO guidelines on the use of uterotonics for preventing postpartum hemorrhage, which also brought a new option, a new tool of a uterotonic called stable carbetocin was very welcome in Nigeria as a potential game changer to addressing some of these challenges. Next slide, please. So just a quick introduction to the team and the consortium. CIDA, Solina Center for International Development and Research, which I work for, leads the consortium in Nigeria and provides technical expertise of the supply chain. We also have CHIDE, Clinton Health Access Initiative, which is the technical lead, and Co-Creation Hub, which is an indigenous Nigeria social impact organization, as the HCD lead on the project. For the first innovation, which we're going to be speaking to you about, we also have our colleagues from McKinsey and Company, who were the design partners. And Montana, Sophia, and Peter are joining us on the webinar today, and will also be making presentations on that experience. Of course, MSD for Mothers supported this program with funding and continues to do so. Next slide. Next. So I'll do a quick introduction to the aims of the project as well as the different innovation spaces. So the aim is to reduce postpartum hemorrhage by 20%, working with the government of Nigeria collaboratively in Kano, Lagos, and Niger states of Nigeria. I will speak a little bit more to the states by 2022. However, our goal was putting human-centered design at the center of what is done, so that we could not just address the challenges through innovations, but make sure that they were brought lasting change and were sustainable. We also aimed to build the capacity of the government to use human-centered design as an approach going forward for other interventions. So today we're going to focus on the first of three innovation spaces, and this speaks to the rollout of the roadmap for the Innovation One, which tries to push down the WHO recommendations for prevention of postpartum hemorrhage and focusing on the introduction of this new uterotonic product, stable carbetocin. In the future, we're also going to be focusing on innovation spaces 2 and 3, where we focus more on clinical care and then supply chain for Innovation 3. So at this point, I'll hand over to Montana, who will now start the discussion on the details of how we executed the design for Innovation One. Over to you, Montana.
Wonderful. Thank you, Uche. My name is Montana Cherney, and as Uche said, I was part of the McKinsey team who led the human-centered design work for Innovation One. And before we get into the rich content, what I'd like to do first is just give a general introduction to the overall human-centered design process that we use to really guide the collaborative engagement with end users and other key stakeholders at each step of the process. So the first step of the process is co-research. And this part was really about capturing the needs, motivations, and behaviors of end users and other key stakeholders to identify opportunities for innovation. This is really about opening the aperture to better understand all of the factors that influence the successful rollout and adoption of the recommendations, as well as the introduction of heat-stable carbetocin, including some pieces around the product pathway and a woman's journey to deliver safely. So after we open the aperture, then we actually close the aperture again, pulling together the insights, the needs, the motivations, and behaviors to identify opportunities for innovation. We then move on to the co-design phase, where we come together and we collaboratively brainstorm many ideas that may serve to meet the needs and motivations of end users and key stakeholders. And in this phase, it's really thinking about creativity, about coming up with as many ideas as possible to really open the lens to see what's possible. So at the end of this stage, we then further defined, iterated those ideas, blending like ideas together and prioritizing those that were likely to be both desirable to end users and stakeholders as well as viable. So again, a closing of the aperture. And then finally, in the co-refinement phase, this piece is really all about iteration, about prototyping, testing, refining solutions to ensure that they were both meeting user needs, but also would fit within the health system constraints. And now I'd like to hand it over to my colleague Sophia, who will walk us through the co-research process, as well as what we learned and the ideas that collaboratively were created by the teams in Kano, Lagos, and Niger. Over to you, Sophia.
Thank you, Montana. Hi, everybody. My name is Sophia Liu. I'm a designer at McKinsey Design, and I was responsible for the day-to-day design research of this project. So I just wanted to start that by saying that for the 3 months that we were in this project, we wanted to make sure that we had as diverse a research pool as possible, and making sure that we could really bring together the experiences of so many people who are part of a mother's birth journey. So this meant that we had a bit of a challenge of trying to make sure we could capture as many healthcare professionals as we could, but also members of the community, mothers themselves, their families, religious leaders, in a series of semi-structured interviews and chats. And basically, the reason why we decided to do this was so that the people themselves could tell us what they thought the problems were and some of the things that they found challenging, rather than responding to prompts from us. So that was very, very important. And especially I'd like to highlight, because of the diverse nature of our team, those of us who were not Nigerian wanted to make sure that we could really try to understand the culture as best as possible, and also gain trust with people and recognize that there was elements that we would need to collaborate with people on. So we actually ended up, for the 3 states that we were in, Lagos, Niger, and Kano, we actually worked very, very closely alongside state collaborators. So these were all women who were very local and well respected in the area, very well linked to their communities, and also very comfortable with reaching out to new communities and speaking with them about some of the challenges that they might face. This happened right at the dawn of the pandemic. So actually we had to be quite inventive with some of the methods that we were using. And so the entire research process took place in a blend of virtual and in-person research. So this is just a quick overview about how we did that. So we worked as designers as a core Smiles for Mothers team, who facilitated interviews with some design experts and consultants. And we actually had 2 of our consultants based in Lagos who were able to go around and do the research there with some of our supports. And then we also had our wonderful local collaborators who conducted not just translations of interviews where needed, but also a lot of cultural translations. They were able to get a trust and rapport of being locals that we would never have been able to achieve without them, and really were pivotal to this work. And then of course we had the state contributors who took part virtually and were great at listening in with the interviews, supporting our research with lines of questioning, and also providing even more of a cultural context, including brands of soda, which was quite interesting for one of our interviews. And the 3 questions we were really trying to focus on during this approach was: what do healthcare workers know about PPH and how to prevent it? What knowledge about uterotonics exists among different cadres or types of healthcare workers? And how are the risks of PPH communicated to mothers and their influencers? So you can see here we had quite an intense setup of screens. And I think another thing that was quite pivotal to this project was the fact that it all took place over WhatsApp. And this was because it was a platform that everyone was already used to using, but also in a lot of the states that we were in, if it was raining season, there were huge connection issues. And so we actually found that WhatsApp was way better than Zoom or any other software to communicate with people. So again, just to highlight here about how we set up our virtual and in-person blended approach for success. So we had each of our WhatsApp groups for our collaborators, we had regular Zoom groups and check-ins, but we also provided each of the collaborators with some onboarding guides, interview guides, and technical cheat sheets. And I think what I want to really highlight here is how we both learned from each other. So the local collaborators taught us about how to gain trust from community and the sorts of conversations that are needed. And here you can see a photo of one of our collaborators wearing a hijab to gain trust of one of the communities, and really spending time with them for the interview and providing extra insight for us. And then from our side, we expanded a little knowledge about what design research was, and created a toolkit for them so that they could also probe and create their own immersions and photos while we were on the project. And that led to some really exciting insights, which I'll go through later. So this is just a quick overview of some of the really in-depth immersive experiences we had. So with 37 skilled healthcare workers, including doctors, nurses, and CHEWs, who are community health extension workers, for those of you that aren't aware, and also pharmacists. And then we also looked at traditional birth attendants, who are more local caregivers into the community. Their role is either inherited or self-taught. And we also looked at chemists and village health workers. And then lots and lots of different types of mothers who either were comfortable giving birth at home, had multiple children. Some of them were giving birth for the first time. Some of them were more comfortable in private settings. We really tried to get a real range. And then, of course, their husbands, religious leaders, and community leaders. And this went from everything from an imam all the way to someone who was a hunter-gatherer tribal lead in his village. So it was really exciting for me as well. In Lagos, so this is just a quick overview of who we looked at. And the real focus here was to understand what methods were used on educating mothers about PPH and the conditions about certain sorts of delivery. And from this came a really interesting insights into the availability and storage conditions of uterotonics. So if you can see on the left here, we went to a real mixture of urban environments, peri-urban and rural environments. Some environments, such as a relay in the top left, didn't have any car access, and the main route into the community was a bridge. And that's our that's our helper there with the box of research tools that she had to carry over her head to get across the bridge. And I think really what was quite interesting in Lagos was the way that oxytocin market was described. So we heard a couple of times this term Wild West to refer to different types of brands. And I think the efficacy of the drug was really linked to the brand and people's experience of it. One doctor actually likened you to pure water when describing. And also here in Lagos, we actually noticed that some healthcare professionals were aware of heat-stable carbetocin, but were turned off it partly because of cost, but also they found that they were also using oxytocin alongside it anyway. So that was quite interesting, and also the fact that the choice of drug was based on patients' socio-economic status, particularly in more public hospitals, and the way that was distributed was really interesting. Photography wise, and I think this is another thing which highlights how design thinking is really exciting, because in surveys we had a lot of people responding saying, yes, we have a fridge in our facility and the uterotonics are stored correctly in the fridge, such as oxytocin. But actually when visiting the facilities, we found that sometimes temperature monitoring didn't quite meet the appropriate storage requirements, or that packaging itself on the actual oxytocin said, oh, you should store this at room temperature and not even provide a temperature dose. So it's really interesting seeing how those were navigated. Moving on to Niger. So in Niger, we were expanding a little bit more to other skilled healthcare workers, such as the traditional birth attendants, and also focusing a little bit more on the community angle. And what was really interesting about Niger was that their key drug of choice was misoprostol. And this was because there had been a lot of regional changes which had come about by the First Lady of the state government, who was really pushing for the use of misoprostol. And this was actually quite common practice, not just in the main public hospitals, but also in the primary healthcare facilities and also among traditional birth attendants themselves. And we actually saw a lot of people gaining trust in the drug. There were some trials to bring out the drug for mothers to test themselves. But I think what was the main thing here was seeing how there was a completely different best or first choice drug. Another really interesting thing to note, particularly in Chanchaga, which is the urban area we went to in Niger, was the use of storing oxytocin in the fridge. So the facility themselves did actually have a fridge, but it was donated by an NGO. And that meant that, and the NGO had very specific requirements about what could and couldn't be stored in the fridge, and oxytocin wasn't one of them. So it was really interesting to see how some facilities did have access to a fridge but weren't actually allowed to use the fridge. So again, this really sort of furthered our research into infrastructures as well. And then finally, we went to Kano, and again, sort of understanding what is the first choice drug to be using, and also how are people responding to these drugs. And we actually found in Kano that NGOs were again quite prominent in the area, and people actually were really intrigued by NGOs offering misoprostol and certain different types of drugs at a discounted rate, but also looking at what sorts of drugs were really flying and taking off, and those were the ones where the NGO had provided lots and lots of support, or also training materials written in local languages. Here as well, it was interesting seeing lots and lots of different brands of oxytocin available and used. There didn't seem to be one standard brand that fit all. And also, again, a huge variation in how the uterotonics was stored. So as you can see in the middle here, uterotonics was stored in the cupboard in 3 out of 5 of the facilities that we visited. And we also saw some cases of misoprostol available for sale at a private pharmacy. And again, a huge thing to note in Kano, and this was actually very evident even as an interviewer from London, but raining season really had a huge effect in a lot of the places we visited in Kano, not just with network issue, but also in terms of gaining supply of the drug. And there were some issues of supplying oxytocin in some healthcare facilities, which led to some people procuring for themselves. So really, really interesting research and a real breadth. And actually, just as a small side story, we actually were interviewing someone as a lady went into labor in one of our interviews, and it was actually the local collaborator who was there and provided context and, you know, talked us through the situation. So I don't think I'll ever have an experience like that again, but it's really, really eye-opening, and we definitely learned a great deal as a team. And then I just wanted to quickly walk everyone through co-research and co-design outputs that we came up with. So all of this research, all of this rich month or two of interviewing together alongside our local collaborators, we got around 2,000 different findings and observations. And so we spent a really long time clustering these together, working with each other to really double check, is this something we heard multiple times? Is this an emerging theme? And what really needs to be flagged here? And that was then synthesized further into 60 emerging themes, as you can see in this little board here, where we started to really cluster together things both by state, but also finding common themes across the state. And then that led down into 24 insights. And these insights were really the pivotal statements or findings that we found that really helped to push our ideas forward. And then we developed 4 opportunity areas based on that. Just a really quick explanation about how we did this. You will hear the word journey a lot, but that's because there are so many different journeys about how these guidelines are actually rolled out and how they're actually received by the mother. So we decided to split this into 3. The first was about guidelines rollout and the adoption journey. So how this works for health system stakeholders, and how are these reviewed and contextualized to ensure that they actually are disseminated. And then secondly, we had the product pathway from procurement to administration. So this was all about how the uterotonics themselves made it along the supply chain to get to the healthcare facilities. And there were lots of cold chain examples put in here too. And then finally, how that drug then arrives into the mother, and looking both at the choices of drug available in each area for the mother, but also the decisions that the mother might make about where to give birth, and how that then influences what healthcare staff or who is available to help them and what ultimately the likely scenarios would be. So a lot of mapping out there. And with each of these 3 journeys, those 24 insights that I talked about earlier were mapped alongside them, so we could really be targeted about what the challenges were, but also where the opportunities might be. And that really helped us to refine some of the ideas going forward. So the 4 opportunity spaces that we came up with were, number 1, how to design a comprehensive publication and dissemination strategy for the WHO recommendations. The second one was all about awareness and adoption among skilled healthcare workers, so doctors, nurses, midwives, the community health extension workers. And how do we empower them about increasing the use of appropriate uterotonics for PPH prevention? The third was among awareness and adoption among unskilled healthcare workers, so such as the traditional birth attendants, and increasing the use of appropriate uterotonics for them. And then finally, how to leverage the community so that health recommendations are fit for the community and also that they are aware for the risks of PPH and the availability of prevention. So after all of this and 2 really wonderful workshops with each of the states, we actually came up with 17 implementable solutions, which all had a cognitive roadmap, and they really targeted how to really get to the heart of what the issue was. So you can see as they're split into 4, there's everything from monitoring guidelines, developing different approaches, all the way down to actually creating PPH ambassadors in the local community, giving communities essential tools in their own languages, which help them to understand a little bit better about PPH. And each of these methods had been really extensively discussed with members of the states, so that it really felt like it was coming from them as well. And I'll just hand back to Uche, who can give you an example of how this is now starting to get rolled out. Thank you.
Thank you so much, Sophia and Montana, for walking us through that incredibly detailed and rich findings from our Innovation 1 journey. And just taking it from there, the design was not meant to be on paper, it was actually meant to be implemented. So I think the first activity we needed to do after working with the states to come up with these different solutions was working with them to make sure they incorporated some of the priority solutions into their annual operational plans. So just a quick description, the annual operational plans are the plans that the states put together at the beginning of every year and guides the implementation of primary health care and other health interventions. So typically having an activity or intervention on that plan meant that it ultimately got done and it was owned and driven by the state government, which is really what we aim to achieve. So for Kano and Niger examples on this slide, and please, these are not exhaustive, we pulled some specific activities that came out of this design that are part of those plans and being implemented in the states. One example at the top is really around integrating the new guidelines, the content of that, into existing training programs for the health workers. And with that, we see that the different state governments have protocols for postpartum hemorrhage management. There's a plethora of these actually, some at the national level, but others at the state level as well. So some of these include training manuals like the BMONC, life-saving skills, the essential medicines list that ultimately need to be amended if a new drug is going to be introduced. So all the states actually have these interventions or activities as part of their plans for this year. And this came out of the work and design that Sophia already spoke to. Secondly, we also have an example on there about the training and just working with the states to design effective training approaches using adult learning techniques to transfer the skills of the new WHO recommendations on PPH prevention and management for skilled and semi-skilled workers. And some of these included innovative mentoring schemes, ideas that also came out of the design. There's also ideas around putting stickers on proper storage on equipment. As Sophia mentioned, you found cases where even cold chain existed in the health facility, but they would still put oxytocin in a cup. So these discussions using those approaches to make sure the changes transition are part of what's on the plan. On the aspect of the community as well, there are also interventions of working with the health education, communication, training, and information centers, which exist in some of the ministries of health, like in Kano, to develop and print education materials that work through what we got in the design and target specific messages to pregnant women across their journeys of maternal health. And also working with the World Development Committees, which are typically led by influential members of the community, traditional leaders, religious leaders, as well as the health workers, to make sure this information was transmitted to the mothers at the right touch points, at both the facility, but also in the community. Next slide. So with a lot of the implementation activity now going on from the design of Innovation 1, the next slide I'm going to present now speaks to what we're doing next in terms of Innovation 2 and 3, as well as specific interventions to support the rollout of heat-stable cavitocin, which is a key component of the revised WHO guidelines. Next slide, please. Thank you. So for Innovations 2 and 3, as I had mentioned, Innovation 2 focuses on strengthening service delivery and improving the quality of services delivered at the health facilities. So some of the themes which we're exploring include addressing the knowledge gap through competency-based service trainings, institutionalizing the use of data, as well as strengthening quality improvement at the health facilities and improving quality of care. For the supply chain, there are also interventions that or themes that address some of the core issues that Sophia had mentioned in her presentation. Some of these include issues around quality. How do we work with the state and national governments to publish information on quality certified uterotonics? Because you found a lot of commodities that didn't meet the criteria were found on the field, both in the public but also in the private sector. We're also looking to strengthen logistic management information systems and explore innovations that tackle that. We're looking for innovations that also enhance the procurement process for uterotonics to improve efficiency and also ensure the states get value for money, as well as exploring integration of uterotonics like oxytocin that require cold chain with the vaccine supply chain infrastructure, which typically is stronger. So again, we're going to be working with the states using these themes to develop innovations for 2 and 3 and coming up with roadmaps to enhance what we're already doing in preventing PPH. Finally, for the heat-stable cavitocin introduction, a lot of what we discussed today are the precursors to making that happen. However, we're following through with our work in the state over the next 6 months to 1 year to conduct targeted advocacy through business cases for new uterotonics, especially heat-stable cavitocin. We can see that the maternal health caucus already has rich resources, and we'll also be looking, to some of those to learn what you've done and incorporate it as we make the business case to both the national and state government for the new drug. We'll also be incorporating heat-stable cavitocin into the supply chain system at state level. We're already doing some of those by updating the essential medicines list to contain these products. That has been done at the national level, and now we're working for all the states to also adopt that. And finally, we're also working very hard to assess the fiscal spaces and make sure sustainable finances, both domestically but also from donor resources, are available to sustain or buy these uterotonics. So thank you very much again for listening and the opportunity to present to you. We'll take a pause now and work with Milka to go over any questions you have. And of course, as we said, look forward to coming again in the future to speak to our journey implementing some of these innovations. Thank you.
Thank you very much for such an illustrative and very well done presentation. Wonderful work. And we're starting to get some questions. So we have one from Melanie Joyner. Could you share more about how capacity was built among government and public health partners to implement human-centered design for other areas in the future? Also, were both public and private sector providers involved in this intervention?
Sure, and maybe I can take the question on the human-centered design capability building. So if we recall some of the earlier discussion on the process, as Sophia mentioned, we had 2 key workshops in each of the 3 states. So we did 6 co-creation workshops in total. Where we involved several stakeholders from each state to be a part of the process. And I think we needed it also because, you know, the ideas that were developed need to be developed collaboratively in order to meet the needs of end users and stakeholders, in order to be desirable to end users and stakeholders, and in order to be viable in terms of fit within the health systems. And so each of these workshops, I believe they're around 2 to 3 hours each. And what we did is in part of those workshops, for the first one, for example, we shared some of the insights that we were learning along the way in the co-research process as we traveled with our local collaboration leads to each of the 3 states. And based on those insights, we came together to really define the ideas within each of the opportunity areas. So that idea about the stickers on the packaging actually came from a participant in one of those workshops. And the reason why we typically do these workshops in such a hands-on way and being very collaborative is that human-centered design is best learned when experienced. You know, it's not something, I don't see it as something that's rocket science, so to speak. It is something that that can be learned, can be taught. And so we were really, you know, collaborative with all of the stakeholders along the way. And then in future workshops, when we got later on in the process, we brought some of the ideas back and we said, okay, let's come together again and let's refine these ideas together. Let's think about how these ideas might complement existing ideas, or how they might best integrate with what's already being planned, so that we weren't creating something that would be difficult to implement. But so that the stakeholders within the health system could really understand, okay, this is a creative process, this is an iterative process, and they could use some of the tools, or continue to use some of the tools that we had been using during these workshops, you know, further along in this process, or to solve other challenges within the health system that they might face. I don't know, Uche and others, if there's anything else that's helpful to share.
Thanks for that, Montana. I think that's very useful. I think in addition to that, as part of the design of the program of Smiles for Mothers, right from the outset, we had worked with MSD for Mothers to make sure this journey is one where we took the states in a transition way to transfer that capacity for human-centered design. So the idea to have 3 innovations also fed into the capacity building plan, which was, for the first innovation, do quite a bit of the heavy lifting, identifying the champions across the different states at that point, and already working with them to start seeing and getting conversant with the tools. For innovation 2, we're going to take a slightly different approach, which is try to have some of those champions lead while we support them actively, so that by the time we get to innovation 3, we can take more of a backseat, the consortium partners, and watch as the states can do that. Of course, this assumes that we have a very strong monitoring and evaluation system in place, which we also have to see how much the states take up the capacity that they need to execute HCD in the future, and we'll continue to track and work closely with them. So that's the design. I think also in addition to that, there are other programs which we've also identified that are looking at the same ideas beyond Smile for Mothers, that are also working in the health space and using human-centered design. So part of what we intend to do is to make sure we're mapping stakeholders together with some of these programs in a collaborative way. So capacity building can also be condensed and applied to the different levels that need to apply them, from the leadership team, but also the people that do day-to-day operations, to make sure capacity is transferred. I think as part of the question, there was also the question of whether it was both public or private sector. So the Smiles for Mothers project had a very strong, or has a very strong leaning for public sector. So a lot of the stakeholders that we've engaged so far are on the public sector side. Thank you.
Thank you, Uche and Sophia, for that comprehensive response. We have now a question from Dr. Salisu Ishaku from Nigeria, and his question is, apart from the 3 states where the research took place, how is the country and other states benefiting from this recommendation? Secondly, are these recommendations final, or are they still under testing? Who would like to take that question?
Yes, so I'll start and I'll let Montana and Sophia jump in as required as well. So if the question speaks to the WHO recommendations, then that's not a work in progress. That was already launched and approved by WHO. I think the discussion is really around the adoption within the country in Nigeria. So I think we're on that journey. I think at the national level that has been adopted. The work we're doing is working with other states to do that. And of course, the question is very important because Nigeria, for those that know, it has 37 states. So 3 is just a drop in the bucket. So what we've done is work as we're trying to introduce and adopt the policies or the recommendations. The idea of selecting the states were very important because the plan is for scale. So we have selected Lagos, which is in southwestern Nigeria, largely urban and the commercial hub, but also selected Niger, which is in north-central Nigeria, and Kano, which is in the northwest. We believe part of selecting these states also made sure that as we apply the adaptation, the lessons we learn are possible for us to disseminate across different states that have different profiles that tie with each of the selected states. In addition to that, we also did a very strong national engagement at the beginning, working from the Federal Ministry of Health, the National Primary Healthcare Development Agency, as well as the different regulatory bodies that oversee health workers across the country, to make sure with that level of buy-in, whatever results we achieved and lessons we learned from the 3 implementation states, to use the Ministry of Health as a champion, but also a disseminator across the country. This also applied to the National Primary Healthcare Development Agency, which had also set up a center, an emergency center for maternal health, and also has direct interactions with all 37 states. So using these platforms, the aim is to continue to disseminate as we learn and make sure we scale as we go. Again, we're still in the early phases. We're done with the design, and we're going to be sharing how that was done, just as we're doing on the webinar. But as we start to implement as well, we aim to use those platforms to continue to share with other states in Nigeria, but also hopefully to a global audience, just as we're doing today. Thank you.
Thank you. Debbie Armbruster from U.S.A. In this slide, you only speak of skilled and semi-skilled, but the earlier slides talked of traditional birth attendants as unskilled, though many do have skills. Are you working with and training TBAs to address PPH? Thank you for your response. TBAs, are they being trained?
Yes, so I'll speak a little bit to that, and Montana and Sophia can also jump in to provide some of the findings we had on Tbas. So again, the slide we presented in terms of implementation was not exhaustive. So definitely, we appreciate that Tbas play a very important role in maternal health. As part of the program and as part of the design, part of what we found was their role was most critical in the referral of pregnant women to the health facilities to seek care. Many other programs already exist that are utilizing TBAs in this way. And interestingly, a lot of the innovations and ideas that we got from the States was reinforcing that fact about using TBAs who have the direct contact with men in the communities, especially in more rural areas of Nigeria. In our case, in Niger and Kano, but also in Lagos, where we have TBAs that have gone through some form of accreditation process. So a lot of what we have in terms of what we're doing is supporting them to strengthen that referral to the health facilities. And of course, working with them to make sure they identify some of these danger signs of pregnancy, including bleeding, and making sure women are referred to the appropriate places to seek care. So at Montana, I don't know if you have any to add in terms of our findings on TBAs. Over.
Sure, thank you, Uche. And I definitely think really thinking about, strengthening those linkages. The reason why we did include TBAs in the initial co-research phase was really to understand all of the complexities and the intricacies of guaranteeing safe delivery for women. And I think that this was important for us for two reasons. Number one, because of really understanding what are the pieces that sort of drive choice in terms of delivering in a facility or with a skilled healthcare worker, such as a midwife or a doctor in the facility. And then also really thinking about how a particular context in a particular state could actually determine the mix of the type of healthcare workers available. So knowing that in more rural areas, that TBAs were potentially more often used, but more importantly, I think that the mix of the uterotonic choices were slightly different based on that context, where in an area where the cold chain might not be able to be maintained consistently, that choices such as misoprostol or even heat-stable carbetocin would likely, be higher on the list. So that was the reason why we were exploring.
Okay, thank you so much. Holly Burke would like you to repeat what the innovations are. Is the use of the stickers on the products one of those innovations?
Yes, so I would say that the innovations are probably on the level of on the dissemination, so using a differentiated dissemination strategy, for example, for the WHO recommendations. Some are around, how to enhance the level of awareness and adoption among skilled healthcare workers, of which there were several ideas that would fit within that overall innovation. I don't know if we're thinking about. I think if we're thinking about the innovation at large for innovation one, it's really thinking about what are the disruptive and differentiated ways to support the successful rollout and adoption of the WHO recommendations, as well as the introduction of heat-stable carbetocin. So when we talk about innovation one, we're talking about it a bit more as an umbrella. And then when we use the term innovation or idea, it's talking a little bit more about dissemination strategies around training or around content, around some of those more concrete ideas that support that umbrella innovation.
We have another question here from Lotte Bengal. Did you in your design include impact assessment and follow-up?
do you want to take that one, Uche?
Impact assessment and follow-up, Uche?
Yes, thanks. So I'll take a crack at that. I think with the design, the focus was, again, identifying the opportunity areas as Montana already presented, and then working with the states to identify those solutions. In terms of impact assessment, I think that's going to come at the level of implementation. So just as I mentioned, the first step that we did to translate the design into an implementable plan was working with the states to incorporate them into the annual operational plans. So part of the process of developing each annual operational plans, beyond the strategies, objectives, and interventions and tasks, is also building in a monitoring and evaluation framework for the trade state to be able to track whether it has achieved this or not. So for those detailed plans in Kano, Niger, and Lagos, which is a little behind, but also coming up with the plan in January, there is indicators to track each and every activity. And this fits not just to that intervention, but how it fits into the broader maternal health strategy of the states, and then, tracking the outcomes at those higher levels beyond just this intervention, but for all the interventions put together in maternal health. So yes, that's built into the annual operational plans, and the states will be tracking the effects of some of these activities as we roll out and implement.
Thank you, Uche. And we have a last question here from Debbie Armbruster. Are the TBAs permitted to use misoprostol or heat-stable carbetocin? TBAs, traditional birth attendants.
Yeah, so thanks. I'll take a crack at that one. I think for heat-stable carbetocin, the answer is no. Not even all cadres of health workers can administer that, and the protocols are very clear for who can or who cannot in Nigeria. And as we engage with the states, heat-stable carbetocin is not yet rolled out. We're in the process of doing that. But different states have even adopted different plans on top on how to do that. Some want to start with the secondary health facilities first and then going down and so on. So everything going to be done is based on the protocols on what is acceptable and what is not. For the TBAs and misoprostol, I think also ultimately the guidance in Nigeria is for skilled and semi-skilled workers to administer that. And the federal government of Nigeria, however, is also instituting an approach to use community health workers. And Nigeria has what we now call a CHIPS program, community health influencers, promoters, and services that are trained to the extent to be able to administer this. So the guidance is very clear. However, our program doesn't quite manage the regulation of what TBAs can or can't do, but we, working with the protocol that exists in the government of Nigeria across the different states, we're supporting the states to be able to ensure that uterotonics have the right quality, but used with health workers that have the required skill to make sure they're able to manage complications and things like that. So I don't know if I've addressed that, but that's a way of saying we abide by the protocols of government of Nigeria for health workers that should use products to use them appropriately. Over.
Well, thank you very much, all of you. Uche, Montana, Olajumoke, Sophia, Peter, you've done an excellent job with this webinar. We're extremely grateful. We will be sharing both the audio and video and possibly the PowerPoint with all the participants. We had 57 participants, so that's great for our first webinar of the year. And I'll leave you the closing words to you, Uche. Thank you so much again for your cooperation in organizing this webinar. So, final words, Uche.
Thanks so much for your support again in preparing Milka and walking us through preparing to make this presentation. As we said, it's an honor. We've been going through the resources as well that the caucus has in place, and there's a lot for us as well to learn from the caucus as we go through this journey. As I mentioned, one example is really around some of these business cases that we intend to make to the government of Nigeria, donors, and so on, and quite a bit to learn from the caucus in itself. So it's really an honor to also be contributing to that body of knowledge. And as we said, we really look forward to coming back again in the future to share our implementation experience, especially with the rollout of his stable capital, and also get thoughts, questions, just as we've done today, through a very interactive session from the caucus on how to improve and do things better. So it's been our pleasure to be part of this as well. Thank you.
Thank you so much. Goodbye.
Bye, thank you.
Bye-bye. Thank you.
Bye.
Thank you very much. Bye-bye.
Bye.